Hello, everyone. Welcome to week 2. This week, we're going to be looking at different types of data in healthcare. We'll talk about some data reliability versus validity. We'll categorize different types of healthcare data. We'll connect the healthcare data flow to different data types and uses, and then we'll look at commonly used sources of external data. When we talk about data validity and reliability, a lot of people use these terms interchangeably. What we're looking at with data validity is the accuracy of the data. In other words, the ability of the data to measure what we want it to measure, right? When we're talking about the reliability, we're talking about the repeatability or reproducibility of the results. So to put into an example, if we have a blood pressure machine that doesn't take blood that give you the same readings for the same observation, meaning the blood pressure, each and every time, it's really not reliable. If we're looking at a blood pressure's cuff's ability to measure blood pressure, that is its validity, if you will. And of course, when we get into validity, we're talking about different types of validity. And here's some examples. Face validity, in other words, does the metric measure the quantity it was intended to measure? So going back to blood pressure, does it, the systolic number over the diastolic number, does it measure what we want it to measure? And again, how do we come up with this? We come up with expert opinions, physicians, scientists, what have you. And we need to get face validity out in front and address that before everything else. Otherwise, the rest of it really won't matter. When we talk about content validity, we're talking about, are the components of the metric necessary and sufficient to measure the quantity? So another primary care example would be content validity in terms of what has better content validity? Is it your total cholesterol, or is it high density lipoproteins versus the ratio for low density lipoproteins? Are these necessary? Is total cholesterol giving us the entire picture about the data validity? Then we have construct validity. Is the measurement tool capturing construct to be measured? That's kind of obvious. And then finally, criterion validity. Does the metric, in other words, agree with an accepted gold standard for measuring the quantity? And we see this a lot in different things with primary care in terms of A1C, hypertension, and some of these other things that we hear talked about, especially in terms of HEDIS measures. The types of reliability, when we talk about reliability, is one that we see a lot in health information when we look at coding audits and what have you. The inter-rater reliability. And basically what this is, if we have two similarly trained coders and they code the same hospital discharge, will they get the same result? Will they get the same primary diagnosis? Will they get the same MSDRG? The intra-rater reliability is talking about something similar, but we're talking about reproducibility, in other words, consistency of the measurement over two different time points using the same rater. So two different reviews. And then we have statistics that talk about this, right? So they measure inter or intra-rater reliability. And if you take a statistics class, they'll talk about the COPPA statistic and the Cohen's COPPA and all these other things. But a generally agreed upon agreement on this is 0.41 to 0.60 is a moderate level of reliability. 0.61 to 0.80 is substantial, and 0.81 to 0.10 is almost perfect. The Cornbach's alpha measures the internal consistency between questions. An acceptable level is greater than or equal to 0.7. Now, with electronic health records data, we have a huge amount of internal data to the point where some of it almost seems superfluous or not needed. And a lot of this comes from the electronic healthcare records, the EHRs. Now, a lot of this information, particularly discrete data, blood pressures, weights, BMIs, are in tables. So we can run reports, as we'll see later on, that give us all the people who have a blood pressure over a certain value, or everybody who has a BMI of a certain amount or less. We also have claims or billing data, and these are used not only for financial administration and reimbursement, but for other things, right? Looking at what our number one payer is, what our most frequent coded reason for a visit to a physician's office, and so on. And then we have the concept of registries, which I believe we've touched on in earlier courses. Registries that can be either internal or external. Most of the time we think about registries, we're thinking about these types of electronic databases on such things like cancer, what have you, right? And this is where some of these data on cancer 5-year survival rates come in from. So we can have somebody who has a certain reportable cancer type, say malignant melanoma, they're in a cancer registry, we track them, we see what their outcomes are, and then we get data about not just their specific episode of care, but more global types of data, their ethnicity, their zip code, some of these other things. And these can either be statewide or even nationwide in the case of a cancer registry. And they were other registries that we also have, trauma record abstract registries, and so on. Medicare claims also keeps a huge amount of data. And these are used to compare hospitals to certain benchmarks for both quality and quantity. And now with ICD-10-CM, which we went to finally in the year 2015, we have the ability now to share data more easily with other developing countries. ICD-10, of course, is developed by the World Health Organization, and the clinical modification, the CM, means that it's used for purposes in the United States. Originally, ICD was used as disease tracking, but now in the US, it's used as a payment driver. And we see that, as you've learned in some of our other courses, about how that plays out with HCCs, MSDRGs, APCs, and so on. With diagnostic data, the inpatient perspective system is a payment system. It's basically looking at similar cases and grouping them for reimbursement. And CMS pays for those services, if you will, based on these groupings. And the premise is that these disease groupings will require similar resources, and that gets into the DRGs. We group these diagnosis-related groups, or groupings of diseases and procedure codes, and then this gets into major disease categories, and then this is the basis for hospital reimbursement. And this is in your book on figure 2.1. So we see over here I-50.4, ICD-10-CM code for combined systolic and diastolic congestive heart failure, right? And we have all the other different subsets of heart failure, right? We have the PCS code that we talk about in HIM 271. So the first three characters are the section, the body system, and the operation. Then we get into the body part, the approach, the device, the qualifier. It's always 7 digits. And this gives us very discrete level data, very fine level of detail on the procedure codes. We also collect data from the medical office using procedure codes in CPT. So you can see here the 99201, level 1 office visit, and so on. So we can use these, put these into a relational database of some sort, even on a national, local, or even a medical office level, and then pull reports. How many heart failure patients did we have? How many people with a level 5 office visit, and so on. And we're not limited to just procedures and diseases. We also have drug codes. You can see some of these examples, other therapeutics, and everything else. But the process is very, very similar. These all go into a database. We can pull this data, look at reports, what have you. And then we have administrative data. In addition to the coded data that we see for diseases and procedures, we have revenue codes. We have place of service codes. We have claims processing codes. And of course, as we learned about in HIM 222, we have relative value unit data as well. So what is a revenue code? Basically, this is categorizing charges into a department. So you can see some of them here. Revenue code for a semi-private room is 0120. Revenue code for pharmacy 0250, and so on. And this is a way of categorizing these types of charges and allows us to compare departmental charges and cost between hospitals, between providers, and so on. Our place of service code is specifying the type of location that the healthcare service was performed. This could be 01 in the pharmacy. Now we have one for 02, which is telehealth, 09, prison or correctional facility, and one we're all familiar with, 11, which is the office, if you will. And we have other locations, SNFs, hospitals, they all have a place of service code. So how does this data flow? Well, basically, it starts when the patient registers. All of us have signed up for health insurance or been seen, and they validate our demographic data. They look at our health plan card, they check for our insurance, they look at our group number, and so on. Then we get into the treatment data flow. And this is where the provider takes a complete health history, looks at diagnostic procedures, therapeutic procedures, what have you. And then there's the claim data. In other words, all these services are coded, and then the codes are mapped to some sort of a reimbursement system. Could be an HCC, could be a fee-for-service, fee schedule, what have you, and then reimbursement is requested. With claims data, we think of 2 different types. And they're paper versions of this you see in different textbooks, but the majority of these are electronic. And these are the UB04 claim form, also known as the CMS 1450 that we use for hospitals. And then we have the CMS 1500 form, the physician services. And that's all I have for you. Come back for our next video lecture where we'll be talking about some more different types of healthcare data. Bye now.